OCD. He's so OCD. We hear that often today. Everyone today is an expert, or at least conversant in psychology, and this is one of those terms that's used freely to describe ourselves and others. Obsessive-compulsive disorder is a classifiable mental disorder that is found in roughly 2 to 3% of adults and 1, perhaps more, in children. Yet we use the term often too loosely to describe certain behaviors that roughly fit the description and thus create confusion about the true meaning of this clinical disorder. I'm Pat Kazakoff, and this is Clinical Insights. Today we'll be speaking to Dr. Robert Ham. He's a clinician with over 30 years of experience in West Hartford with many different disciplines. Stay with me, and we're going to be speaking to Dr. Robert Ham. Okay, so now we're just talking, and this is fine, okay. So Dr. Ham, what exactly is OCD?
Well, there's, I think, a common misconception about what this disorder is. So, as you were saying, many people identify it as something that many people commonly experience that we call OCD, and unfortunately, I think the internet contributes to misconceptions about it. But strictly speaking, it is a mental disorder classified as an anxiety disorder.
Well, you said there's two parts to it, the obsessive and the compulsive.
Right, exactly.
So what's the obsessive part and what's the compulsive part?
In these two parts, they can come together. A patient can suffer from both of them simultaneously, or some people have one or the other, more or less. So the obsessions, as the name implies, has to do with our thoughts. It's an idea or ideas, thoughts that are intrusive. We call this intrusive thoughts. I like to call them sticky thoughts because it's like flypaper. Once you have a thought, it's like a song that you really hate, can't get out of your mind. The more you try to get rid of it, the harder it is.
But when, for example, like a normal person, I have thoughts that I don't want to be thinking about.
Mm-hmm.
So when does it become obsessive? Like when is it too much? Because you can describe almost anybody with an obsessive thought pattern at certain times of their life.
Yes. Well, I think many of us, nearly all of us, I would assume, have obsessive thoughts, so for various reasons. But with OCD, it's more specific and it's more troubling. The obsessive thoughts are often out of character. They are disturbing. They might have something to do with violence or sex, something that is rather extreme. And a person finds themselves intruded upon by these thoughts, not knowing where they came from, very confused. It can be frightening.
So in other words, a normal person comes in to see you,
Mm-hmm.
and they're thinking about their dead mother, but their mother's not dead. Would that be called an obsessive thought?
Yes, it could be. But with OCD, usually the types of thoughts that people who suffer from this disorder have to do more with something that they produce themselves, such as not only that their mother is dead, but they themselves caused their mother to die in some way. Let's say they murdered them, or they had some infectious, contagious disease that their mother got. So it often involves a feeling of guilt, which compounds the disturbance of the thought. And it's so out of character. I mean, these are thoughts that people who suffer from this disorder, again, it's an anxiety disorder, not an impulse control disorder, so to speak. They're the least likely person in the world
to do this.
To actually inflict this kind of behavior on somebody.
So does a person identify themselves when they come in to see you? Do they say to you, I have OCD, or how do they identify themselves in order to come to see you?
Well, I think that most people who come in to see me with this disorder, they have the compulsive part. But a person who has obsessions, often it goes hand in hand with the compulsions. But yes, it's so disturbing. A person who has these kinds of obsessions, they are troubled by it. One reason being that they're fearful that it means that they might act on that impulse.
And what about the compulsive part of it? What is that? How does that present itself?
Well, it's a misconception, as I say, that many people confuse impulse control disorders with compulsive behaviors associated with OCD. And the difference that I try to explain to people who have questions about this, an impulse control disorder involves some kind of behavior, such as gambling, overeating, drinking, sex, something that is inherently pleasurable.
So the distinction is pleasurable versus unpleasurable? Is that the distinction between impulse control and OCD?
Yeah, basically, inherently, and that's a key word here, because an impulse control disorder can get out of hand and cause a lot of havoc when it develops into an addiction, let's say. A compulsive behavior is distinctive in that it is something that is unpleasant by nature or takes on an unpleasant quality because it becomes compulsive, such as washing one's hands or checking things constantly, or something that we call in clinical practice symmetry compulsions.
What's that called? Symmetry?
Symmetry compulsions, which is the feeling forced to do things in even numbers, let's say. So if you do things once, you have to do it twice. So these are behaviors that don't make sense often. They take on dimensions that become obsessive and can take up a lot of time in a person's life. They're not inherently pleasurable, but nonetheless a person feels forced to do them. And that is what distinguishes a compulsive disorder from an impulse control disorder.
So are there, when you look at people, you said that there's 2 to 3% of adults who have this. Are there certain characteristics in these adults that you could have predicted they would have this kind of anxiety disorder? Like when you look at them as a whole, is there something predictable about these people getting this disorder?
Well, as far as the causes, they're not certain, but certainly I think heredity, as always, plays a role. Sometimes it's our childhood, some kind of dysfunctional childhood factors that may contribute to it. But as far as being able to identify this in a person that you meet, if you didn't see them engage in, let's say, a compulsive behavior, would you be able to identify them as someone who is susceptible? Not really, except that, again, this is an anxiety disorder. So it can manifest in different ways as anxiety, OCD being one way. So if it's someone who is susceptible to anxiety in its various forms, we see someone who has an anxious, fearful nature about them, I think that increases the likelihood that they could be suffering from this particular disorder.
You mentioned the genetic factor. And not the genetic factor, you mentioned the childhood, something in their childhood. What something in their childhood would predispose a person to this anxiety disorder? Is there something specific?
No, there isn't.
Okay. That's a simple answer.
Yeah, not that I know of. I don't think so. I mean, it's so difficult to really sort of sort out the epidemiology when it comes to lifestyle or childhood histories. So a person could come from a family that was divided, there was a lot of turmoil or instability, or the more classical childhood experiences contributing to OCD where their parents were too strict and the child develops anxiety and a fearfulness about violating certain expectations or rules.
Right. And so this genetic component is just basically part of this also, that your parents had this or someone else had it, or that you grew up in an anxious environment.
Yeah, I think that most mental disorders, as most things in life about us biologically, is probably at least half hereditary. So we can often identify people with this disorder as having a family history, either of OCD or some kind of anxiety disorder.
What about, I've also heard of OCPD. What is that?
Well, good. I'm glad that you brought that up because most people are not familiar with that term. It refers to obsessive-compulsive personality disorder.
So how is that differentiated from OCD? What's the difference?
Well, the difference is one is a personality disorder and the other is an anxiety disorder. So in clinical practice, we refer to personality disorders as something that we call as being egosyntonic.
Ooh,
There's a nice fancy term for you.
Egosyntonic.
Right.
And what does that mean?
It means that it's the behavior, the disorder itself is consistent with one's personality, and that can make it difficult to treat because a person is not able to identify the symptoms of their personality disorder as problematic.
So in other words, their wiring is that they're born with this kind of thought pattern?
No, that's not what I mean.
Is that what you're saying?
No, that's what I mean is a personality disorder is difficult to treat often because a person who has a personality disorder, whether it's narcissistic or obsessive-compulsive, is a part of who they are. So they don't see that about themselves because it's part of the background that constitutes their identity, their perceptions. And so they don't see themselves as having a disorder. It's everyone else who has a problem.
Ah, they don't identify themselves.
Right.
So they would not self-identify and come to see you and say, I have these obsessive thoughts.
Well, no, we're talking about a personality disorder now, not someone with OCD. So maybe I should just try to, again, sort of flesh out the differences, get back to your original question. The personality disorder was originally identified by Freud. It's called the anal personality, and it might include symptoms of rigidity, someone who's very rule-driven and doesn't bend, doesn't yield, and becomes very difficult to deal with if you have to deal with gray with that person. So they can be oppressive to be with. Punctuality, stinginess. This is part of what Freud called the anal triad, and Carl Abraham, who specialized in this. That's OCPD, what we call OCD, and that's PD. That's a personality disorder. OCD, strictly speaking, is an anxiety disorder. It's ego dystonic, which means that a person who suffers from these symptoms doesn't identify. It's not part of their personality, so they'll say, I feel very uncomfortable and confused why I'm having these obsessive thoughts or why I feel compelled to constantly be checking the stove before I leave 100 times. I don't want to do this. It's not like me. I'm having thoughts of murdering somebody, and I don't know why. I would never even. It's inconsistent with my personality. It's not part of my character. That's ego dystonic. And that person is more inclined to see a therapist because they don't identify with their disorder. They view it as something that's foreign to them
Outside
and disturbing.
of themselves.
Outside and very disturbing.
So can you cure OCD?
No, even though it is a disorder and we have treatments for OCD, it's not curable per se. It's treatable. We can help to diminish the symptoms and the distress associated with the symptoms. But OCD is something that one has for their entire lifetime. And in clinical practice, I have found that it comes and goes, waxes and wanes, according to stresses in a person's life. Stress will induce fear and anxiety. And again, OCD, strictly speaking, is an anxiety disorder.
So what would you do? How do you change, because these are behaviors. How do you change behaviors? Like, they might have the disorder OCD, but if they're not doing the behaviors, aren't we home free?
You're asking me if you don't give in to the compulsions?
Right.
Well, that helps, and it does help alleviate and helps them to manage the symptoms. However, it doesn't cure the disorder. Those predilections will always be there in some form or another.
So how do you try to cure this? Because the person is suffering.
Mm-hmm. Sure. Well, if a patient sees me for this disorder, I sometimes will give them a test, a screening test for OCD. Sometimes just in an interview, I can identify the disorder and how it's manifest. And then we go over the different kinds of cognitive behavioral treatments for it. And sometimes medication. There are, in those instances, I would refer a patient to a psychiatrist for an evaluation. So sometimes medication in conjunction with psychotherapy is the best course of treatment for it.
What kind of medication would this respond to? Because this is all behavioral, isn't it? Or
no, it's not all behavioral. It's ideational and it's probably physiological. And again, there's a hereditary factor to it. The medications, I'm not a psychiatrist or a medical doctor, but generally they're in the class of the SSRIs that have been labeled by the FDA as particularly effective for OCD, under the class of antidepressant medications. Yeah.
And does a person who have OCD, does he have to see you for the rest of his life? Or is there sort of a treatment time frame?
Mm-hmm. Well, that's a good question. Even though OCD is something that is not curable, you don't have to be in treatment for the rest of your life for it. Although some patients do see me who have this disorder over a lengthy period of time, not necessarily in order to treat this particular disorder, but that the disorder often is associated with other problems in life that the patient would see me, to get help with. But in dealing with this particular disorder on its own, no, it's time limited. So I would help them to learn how to cope with the symptoms. So it might include some behavioral techniques that we call in psychology exposure therapy, which means that you deal with a situation that elicits the compulsions. You don't avoid them. And then response prevention, which
So you have to identify the situations. You have to identify the situation that makes you prone to washing your hands.
Mm-hmm. Right. So rather than asking a patient to avoid those situations, you help them to learn how to cope with those situations so they don't give in to the impulse that they feel compelled to do in those situations, such as hand washing or checking things repeatedly.
So would that be the same treatment for overeating?
No. Response prevention, learning how to deal with the tendency to engage in certain behaviors. Yeah, I guess you might say
well,
that
mind you,
yeah.
if I'm listening to you,
yeah.
Overeating is pleasurable,
Mm-hmm.
which puts it in another category.
Right.
Whereas washing your hands, not so much fun.
Right. Yeah, I guess you might say you're both with OCD and with impulse control disorders, you're teaching a patient to identify what situations these behaviors they engage in, triggers that elicit those behaviors, stresses such as boredom or stress or an argument that you're having with a significant other. And then learning coping mechanisms, how to engage in alternative behaviors to replace the dysfunctional behavior that you're treating.
Addictions, are addictions part of this too, or no?
No, well, it's a different kind of disorder. An impulse control disorder, such as gambling, for example, is inherently pleasurable. So in and of itself, it's not a bad thing. It's something that people, enjoy. It's only when it becomes obsessive or it becomes too much, or it has ramifications that are destructive in a person's life, they can't stop doing it, that it takes on the same sort of dimensions as an obsessive-compulsive disorder. It can be destructive. But the treatment is similar in that you teach a patient how to identify the situations that they engage in that are problematic, triggers that elicit the behaviors. For impulse control disorders, often there are certain kinds of emotional states that would elicit that behavior or situations. And then coping mechanisms. So one of the coping mechanisms would be meditative techniques that I teach patients, or to engage in an alternate behavior such as exercise, or engaging in a social behavior. So they would develop a menu of different kinds of alternate behaviors to engage in that are healthier to
And
engage
how
in.
successful, sort of as a like you said, that this disorder, you have it for life.
Mm-hmm.
So how successful is the combination of psychology and psychotherapy and medication?
Mm-hmm.
How successful is it in dealing with this particular, with OCD?
It's very successful as long as you have an understanding that your expectations should be somewhat modest, in that they may resurface at different times in one's life. And many patients still manifest some degree of the symptoms, but they find that they can keep it at a manageable level so it doesn't create problems in their lives. So they may be somewhat compulsive in their behaviors, sort of strict about cleanliness, but not to the extent that it becomes problematic or takes a lot of time in their lives or causing them to, rub their skin so it's raw.
What about age? Do these symptoms wane with age? Is there an age factor in this?
No, it isn't. It often surfaces in childhood, adolescence, but it's something that doesn't go away unless a person seeks treatment for it. It really is associated with anxiety and stress in one's life.
Would you mind if I asked you a little bit about yourself?
Oh, certainly, glad to. Okay.
So you're a psychologist. You've been working in West Hartford for 30 years. What's your background? Where do you come from?
Well, I've been here in the Hartford area, living here for almost 35 years. I have been in private practice the entire time I've lived here, worked in different areas. Developmental disabilities, that's what I worked in when I first came here. That's what brought me here to the state. Forensics, worked for the Courts Diagnostic Clinic in the prison system for a number of years as a consultant on a clinical team. Geriatrics in nursing homes and residential care homes. I've been in different group practices. I was affiliated with St. Francis Hospital for a number of years, but now my practice is strictly located here in the West Hartford community. I work with the general population.
What do you see a lot of in the general population?
Well, I have a general practice. So I have a website, roberthamphd.com, with a blog on various topics and this program. that are related to issues in society, related to psychology, and my private practice. So some of the areas that I specialize in are spirituality, personal growth, relationships. I work with individuals and couples and families, and mental disorders such as this one, obsessive-compulsive disorder, and a host of other anxiety disorders, mood disorders, anger management, communication skills training.
So basically, the gamut.
A lot of things.
Is there one anxiety disorder that is more prevalent in the society that you see more of than anything else?
Yeah, I think that the probably the most prevalent disorder is what we call generalized anxiety disorder. Many people suffer from anxiety to different degrees. Generalized anxiety is kind of a diffuse anxiety. It sort of stays with you. Some people aren't even aware of it. So learning cognitive therapy, which I teach many of my patients, and meditative techniques, the one that I use is called autogenic training, helps people with a host of different kinds of problems, especially anxiety disorders in general.
So you said you have a website?
Yes.
And also, where are you located?
I'm right here in West Hartford Center at 10 North Main Street.
And what about a telephone number? Can people contact you by telephone?
Certainly. My office phone is area code 860-236-2131.
Is there anything else you want to tell me about yourself that I haven't asked you that would be helpful to the people listening?
Well, about myself, I'm personable, sensitive. In my practice, I use different kinds of modalities. So I was speaking with you, Pat, about cognitive therapy, which is working with our thoughts, behavior therapy, our behaviors. But I also work with symbolism. I help a patient to understand the meaning of their disorder. So I help them, like with regard to OCD, help them to understand that what they're suffering from is really quite human. So our compulsions are a remnant of magical thinking that goes way back to prehistory, before science, and when compulsions were used as a way to ward off things that we didn't understand. So helping patients to understand that, or an intrusive thought to help them to understand that it might have some symbolic significance that's useful to them. So it helps to humanize them. So I try to also relate to my patients as people. Yeah.
We've been talking to Dr. Robert Ham. Dr. Robert Ham is a clinician in West Hartford with over 30 years experience. And his practice is very general. Today we're talking about OCD, but next month we're going to be talking about another anxiety disorder. I'm Pat Kazakoff. You've been watching Psychological Insights with Dr. Robert Ham. Thank you. Because